Editor-in-Chief of DevX, back with you to have another conversation with a global health leader in the series of discussions we've doing with leaders from all over the world. And I'm really excited to have Charles Holmes with me today. Charles is a medical doctor. He's a global health leader who's had an incredible career in this field. You're right now at the Georgetown University Medical Center, Charles, where you're the faculty director for a center there on health policy and innovation. You've come back fairly recently, just a couple of years ago, from leading a major national NGO in the global health space in Zambia. And before that, you were the chief medical officer over at PEPFAR, which is, of course, the big HIV/AIDS treatment plan of the US government, biggest global health program in the world. You've got this incredible background and career working across global health. So I'd love to get a little moment to hear from you, your take on everything that's happening today. Thanks for taking some time to be with us.
Yeah, well, thanks so much, Raj, for having me. It's really always a pleasure to talk with you, and always enjoy it. So yeah, I think it's we're at a really unique moment, aren't we? It's an extraordinary time, and I think each of us each of us are kind of grappling with it in our own way. Looking globally, this really is beginning to feel like the largest public health crisis, since the 1918, Spanish flu epidemic.
And do you feel that, including looking at the global South, because, there's still a lot of people who say the numbers aren't that big. Of course, there's a question about testing capability. You've got a lot of experience in the countries we're talking about in the global South, specifically in sub-Saharan Africa. How do you see the pandemic situation there right now?
Yeah, well, I think it really is evolving day to day. I think that what we've seen is that many countries in the global South were able to lead and take public health actions that were prescient, right? You had countries there that were able to look and watch how the epidemic and pandemic then spread across the North, and they, in coordination with the Africa CDC and the WHO, were able to take some strong and swift actions to in many cases shut down and lock down much of their society in a way that was helpful in blunting that initial, what we thought would have been an epidemic curve that began much like it has in parts of Asia and Europe and then the US. But what we've seen there is that in large part, that epidemic curve has been blunted and flattened in some cases. And that's been due to these lockdowns largely, we think. We know that there may be other factors at play. There's still ongoing discussion about whether some climate differences in climate may contribute to the lack of rapid spread. But we're very uncertain about that. I've seen models that take that into consideration, models that don't. And we also know there's a younger age structure, of course, in the region. But I want to say that I think it's the swift public health action that's contributed the most to the flattening of the curve there. But what we're seeing now is really, really concerning. And what I meant by sort of day to day is that the lockdown is just having these tremendous effects, particularly on those people who are reliant on, daily income from informal sector labor, and they are unable to work. Food sources are being basically choked off because farmers are not able to bring things into urban markets and the like. And you're starting to literally see the beginnings of starvation and other things taking place. So we're in a real balance.
Yeah, well, that's an important perspective, because you and I are both sitting here in the United States, and there's a lot of negative side effects of a lockdown or a stay-at-home set of orders here in the US, and you're starting to see pushback even from the likes of Elon Musk, overnight tweeting about this. But it's nothing compared to what people go through in societies where most people live in the informal sector. They literally need to leave their house to get food. They don't have a source of savings or basic income if they're not working. So, it's been pretty impressive to see how a lot of the countries, not all, but a lot of the countries have really stepped up and put in place orders, even given how onerous they are for their populations, to try to flatten this. So it sounds like what you're saying is you think that's worked to some degree. but we're now seeing the beginnings of an uptick there. Is that your feeling?
Yeah, I think that we're seeing some fraying around the edges of those lockdowns. Unfortunately, they were the right public health action to put into place initially, and hopefully, what that's allowed is for greater testing capacity, and as well as some tracing and other capacity to be sort of mobilized and put into place. But we are beginning to see some fraying around the edges. Obviously, the issues around starvation and the like, but I think also um, as we're seeing more testing take place and as people are beginning to break out of those sort of lockdown situations for their own survival in some cases, the numbers of cases are starting to go up. Look across Africa over the last week, you saw a 42% rise in cases. Some of that was related to the increased testing that's going on. Some of that was perhaps related to what could be a delayed exponential growth of cases. So
I mean, you've got a pretty good handle on the capabilities around testing, because so much of the testing happening now is using the HIV platforms that were set up in the continent. I mean, what's your take on how much of what we're seeing today is just an underreported number because testing, can't reach the populations that it should, or maybe these numbers are pretty accurate because, in the urban centers where the pandemic seems to mostly take hold, at least in the beginning around the world, there is strong HIV testing capacity. What's your sense of it?
Yeah, well, look, I think you're right. What we've seen, because of the investments in PEPFAR and the Global Fund and these other platforms, there is this very strong sort of underlying health system, particularly focused on HIV, TB, and malaria. But we are seeing it pivot, and that's very exciting to see, although that takes time. And, one of the challenges around the testing has been that even though many of the PCR platforms and things are in place, actually getting the reagents and the test kits, and in the case of some of these more point of care clinic-based tests that are available for TB and HIV, we're not able to get those cassettes into the country because there is a global competition for those very cassettes and laboratory reagents. So
it's amazing, yeah, Charles, that's like the same problem we're facing in the United States, right? We have the machines and we don't have the kit that goes along with it, the
right.
swabs and such. And you're saying that's exactly what they're facing in a lot of these lower income countries.
It is, and I think it. So we're basically under leveraging our system, right? The systems that have been developed are there. Look, countries are doing the best that they can. And we've seen some tremendous coordination, again, from the Africa CDC, from WHO, to get large scale testing reagents, PPEs and other things to countries in a pretty equitable fashion, which is terrific. But we need much, much more than that. And we need, obviously, there are a lot of lessons that we're going to take from this pandemic. And we can maybe talk about that a little bit in the future. But for right now, we're not able to get the testing capacity fully utilized.
Makes sense. I've got a visitor here who occasionally comes into my videos. This is Eduardo making a case. He's learned that this is the good time to ask me for stuff. Let me ask you, Charles, about your take on how the disease is likely to progress from here. In other words, some people because of the climate-related issues, some people because of the young populations in the countries we're talking about, will tell you that they actually think there's a chance we may never see the significant uptake that you've seen in the U.S. What do you think?
Mm-hmm, mm-hmm. Right. Well, I think that there's a lot of projection work going on, and anyone who tells you they know what's going to happen here is probably getting out a little ahead of their skis. But I think what we do need to take into account is that political leaders in the South at this point seem to be acting primarily on public health grounds. In many cases, they're following the guidance from the Africa CDC and WHO. They're looking at the data, and that's critical because this is not just a single decision that needs to be made. It's a day by day. Let's look at the data. Let's begin to monitor how people are doing. Is literally lack of food becoming a bigger issue than the COVID crisis in some cases, in which case you would want to relax your lockdown for a period of time and then potentially re-intensify it. So I think it's going to be a real balance between those issues. And I think that we are going to see fairly substantial growth of the pandemic in the global South in the coming months, despite all of that really important work. And
Yeah,
so
that
I think that
seems to be the consensus
very important
from
implications.
other yeah, that seems to be consensus from other epidemiologists I speak with and other global health leaders that the likely scenario, regardless of the potential upside you have about youth demographics and weather, that the likely scenario is that you're going to see a significant outbreak because those factors might just slow some of the disease. It might reduce the immediate impact of it, but you're still likely to see this pandemic take hold in a big way in much of the global South. That's at least the consensus I'm hearing. One of the key things I wanted to talk to you about is, let's assume that's right, and you do see this take hold a lot in the global South. What is the response going to be like there? I mean, it's fascinating that the former U.S. Global AIDS Coordinator, you used to be Deputy U.S. Global AIDS Coordinator, but the former one, Debbie Birx, is running this coronavirus task force under Vice President Pence for President Trump. She knows this. She knows these countries. She knows these circumstances, these health systems better than anybody. And yet it seems like so far the response and the narrative even here in the US and in much of the world is still just about places like the US and the UK and Italy and Spain and China. What's your take, given that you come from that background, as to how the response will unfold in these countries, in Africa and other low and middle income countries?
Yeah. Well, I'll tell you, like Ambassador Birx, spend a lot of time thinking about these programs and trying to improve them. And I think I have tremendous confidence in the public health capacity that's been built at the moment. It's interesting. There has been much less focus on the tertiary care and the kinds of things that we often focus on in the global North. And there is much more focus on the public health capacity of jurisdictions, of communities, and countries. And so I think that will serve many countries in the global South well. They have a tremendous amount of experience, fighting under 5 mortality, fighting polio, and doing these things very well. 13 countries on the path to eliminating malaria in the region. You've got the HIV, TB, and malaria platforms are probably some of the strongest public health responses we've ever seen in the world, and they are able to pivot. And I'll tell you, from day one, as news of the COVID pandemic began to spread, we began to see governments as well as implementers of programs in the global South, particularly in Southern Africa, begin to take this on. How can we communicate about COVID to not only HIV patients, but to everyone seeking care in a clinic? How can we keep people safe? How can we change our algorithms for care provision so that we protect those existing responses, like the HIV response that require long-term medication, and give those people long-term refills and keep them out of the clinic so that the clinics can be utilized for people perhaps in need of testing or in need of treatment for COVID.
But it's hard to believe. I mean, I'm hearing some of those positive stories too, but it's hard to believe that this won't have a negative impact on the HIV picture. Adherence is already a challenge. Now you give people longer, dosage. That's a good way to try to get at the problem. But still, you're likely to have real challenges. It would seem on HIV, on TB, and on other global health priorities.
Yeah, look, there are real challenges. Let's be clear, and these things aren't um, aren't easy to do. Our systems aren't completely fungible. They require greater resources to be mobilized. And one of the most urgent things is PEPFAR has been tremendously responsive in terms of allowing implementers to flex and to begin to address COVID. But one of the concerns that I have for all of our global health programs, not just PEPFAR, is that they're going to need some backfilling around that. You can't fight a new pandemic while you're fighting the last three all on the same resources. And so I think there are going to be some implications there and some real requirements. I do think that I have a lot of concerns about the way in which some of the programs, particularly that require large-scale mobilization, are going to be affected. Vaccine campaigns, for instance, are not as able to be flexible in terms of their approaches. We've learned over time what works. It's generally large-scale community mobilization, large-scale supply chain mobilization, and the things that are very difficult right now. And so you have seen a number of countries put a pause on those campaigns. And this is what we began to see in West Africa in 2014 and 15, which is, measles immunization rates going down, beginnings of outbreaks occurring. Yeah. And you're right. I don't think that the HIV program or the TB program or malaria is going to be untouched in this. They're nimble, they're doing well, but they need resources. And I do think that individual patients are encountering all the same issues in terms of food security and things that may end up being greater priorities for them than taking a daily medicine, for instance, and ensuring that. So I have some real concerns there as well.
One of the assets that these programs have is the fact that they have moved increasingly over the years to push more of their funding to national organizations in the affected countries. You used to run one of those in Zambia for 4 years, a pretty major one that served hundreds of thousands of patients. And it's a controversial issue. I interviewed Debbie Birx, it seems like years ago, but it was just a few weeks ago, really, just maybe 2 months ago, right before she was appointed to this new role. And one of the key issues I was speaking to her about, because it was so controversial, is this move to have 70% of PEPFAR funding go to, so-called local organizations. You've experienced what that's like. So the organization you ran was a PEPFAR recipient, as well as other global health funding. And so now, and you wrote a piece recently, a great piece on Think Global Health about this issue. So that's one of the key things I wanted to speak with you about. How ready are we today to begin shifting larger sums of money to these national health organizations around the world, given that a lot of the international players can't travel, expats can't get on the plane, right? We're going to need to rely more, just because of the health security issues, on the organizations that are there today on the ground. How ready are we for this?
Mm-hmm. Yeah, well, great question. I think that we have seen a tremendous growth in national public health capacity over the last couple of decades. When you think about what clinical capacity, public health capacity, managerial capacity that's been built largely through these extremely large effective programs like PEPFAR, like PMI, like some of the other TB programs and the Global Fund. That funding over time has enabled public health to strengthen its responses and become somewhat less reliant on folks coming from the outside with the expertise. The expertise that is available in most countries, if you just think about Southern Africa, for instance, is extraordinary. And the people that have been fighting these epidemics there are extraordinarily well equipped to deal with the public health strategies that are needed and to deal with what it takes to run organizations and the like. However, I think there's a balance, right? And we have still enormous public health needs that that exist. And for me, it's less about the speed with which we transition to local partners in general, and more about doing it really, really well. And it's not an easy process to run an organization like that in a country that has extraordinary public health needs, that but where in general systems may be weaker for dealing with issues around fraud and mismanagement and the like. And so it takes a real solid governance structure and management structure, and those things are very possible, but they take time and they take leadership.
Have time right now. I mean, a lot of what we're hearing. In fact, we got a question in from one of our viewers right now about how long do we think this thing goes on? The University of Minnesota estimates saying 18 to 24 months. Many of the people I'm talking to, similar profiles to yourself, are saying, yeah, multiple waves are possible. This is not a short run issue. This is going to go on for quite a long period, even if vaccine development gets accelerated. So given all that, if you're in the global development and global health fields, and you've got all of these other priorities and issues, right, that are happening in health and outside of health, and education and agriculture, you name it.
Yeah.
There, of course, organizations have local capacity today. Of course, there's subcontractors and subgrantees, but you've got to quickly be able to ramp up, I would think, to address, getting money out the door, keeping programs going, addressing urgent needs over the next 18 to 24 months. We don't have a lot of time, right?
Yep. No, you're very right. And look, the first thing to note is that local organizations have been able, in large part, to pivot and to begin to address the new issues that are emerging around COVID, that are emerging around food security and the like. What I think the real barriers are relate to, frankly, some of the restrictions that we have around funding flows, and the ability to get them what they need quick enough to be able to act. They can hire. I have extraordinary confidence that they can train people very well and get them out doing what they need to do. But can they keep the funding coming in a way that's flexible enough that allows them to do their work? Can they get the supplies they need? One of the biggest problems right now is getting PPEs for community health workers. We know that we have armies of public health workers that are able to be mobilized, whether through districts and through governments, or whether through local non-governmental organizations or international organizations that still have a presence on the ground. But we have to be able to protect those frontline workers. And that's absolutely essential. The other quick thing I would say—
we've been reporting on that at DevEx, and it is kind of shocking to hear how many, there's hundreds of thousands, in some countries nearly 1 million community health workers, and in many cases they don't even have a basic mask or gloves, the basic equipment they would need to stay safe as they do this job, and they're being asked to go door to door and to continue to provide all the health services that they are relied upon for. So it's a really big issue, and one that we're tracking.
Yep, it's an important one. One thing I would say is that we need all hands on deck to fight this pandemic. We need local organizations to be mobilized. We need international organizations to be mobilized as well. And one of the strengths of international organizations is that they're able to work across countries and bring best practices across countries and leverage supply chains and the like. Local organizations have more difficulty doing that. So we need cooperation between all parties, but we also need to be working again to sort of break down some of the barriers that exist in terms of getting funding to local organizations and helping them utilize it well under time pressure. And one of the things that I've talked about before is that oftentimes local organizations run up against barriers that may relate to US regulations, and how do we bring those together? Can we use this money in this fashion? And there's not a very clear answer there. We need to come up with some creative ideas so that on the fly, we can get answers for these really dedicated organizations that are doing this work and want to do the right thing, but don't want to run afoul of our regulations and laws in doing so.
Yeah, one of the things you talk about in your piece is how, we might often shift the programmatic funding to these local or national organizations, but we don't necessarily provide the core funding they need to get their infrastructure up to speed, accounting systems and basic management and corporate governance, those kinds of things. If they're not funded, you can give them lots of money to do a program, but they really have to have those core functions to be robust enough, especially to deal with US government requirements and regulations. And it's interesting because the controversy, the reason it's controversial when Debbie Burke says we're going to go to 70% local funding is you've got a lot of international organizations, US based often, that are the traditional implementers of PEPFAR programs. And they say, look, we've been living under very tight regulatory requirements. We've been working really hard to bring in local organizations as subcontractors, subgrantees. We've been trying to make sure there's great cost effectiveness, but we protect the US taxpayer dollar from waste, fraud, and abuse.
Mm-hmm.
And if you just try to rush this money out the door and kind of go around us, and you're going to make a mess of this whole thing, and it's going to come back to bite us. We're going to have money lost. I wonder, even before this pandemic, what was your take on the move to 70%, and on the potential for that to really work versus for it to be kind of counterproductive? What do you think?
Yeah. Well, I think that the idea is a good one, and it's sometimes really good to have a goal and a target. Doesn't mean you're always going to meet it, but it can help to mobilize when there's maybe not a huge amount of motivation to fully mobilize to make a change. We saw that early on in PEPFAR, the transition that we made from our initial 4 or 5 international treatment partners to a whole range of local partners, what we called the Track 1 transition back then, was largely a successful process. It took 3 or 4 years to make it happen, but it worked, and it stood up a lot of the organizations that are still going today and providing high quality care and public health programs. So I think it does take time, and I think some agencies have a head start. You look at what CDC has done over the years. Many of their agreements have actually been directly to governments, helping to establish national public health institutes, doing direct government to government cooperative agreements, even down to the district level to support that infrastructure. USAID has been more oriented towards funding organizations and others to do that work, and so I think they were starting from a different place. So for me, I wouldn't weigh in on whether that's the right target or time frame, but what I would say is that there is a risk, and the risk is that you don't think enough about the underlying elements of what makes for a successful organization that's going to last for 20 years or longer. If you don't make those investments up front, as you were saying before, in the management, the governance, the finances, you potentially are setting up an organization that's going to fail in a couple of years. And the transactional costs of that, for public health and quite frankly, for the taxpayer, are not great. And we should be mindful of the fact that an extra 10% or an extra 30% spent now to absolutely ensure that the systems are in place for that organization to be successful, even if that means they can't test as many people in that first year, are going to pay off in spades in the long run. So that's really what I would focus on most if I was sitting in one of those positions. Yep. Is making sure that we were taking a long-term view and taking really a development lens to thinking about these organizations, because they really are the essence of where we're trying to go with development, which is to have permanent local capacity that's able to take on not just one disease problem, but to really support the broader health system and further the development of the countries that are our partners in many.
And it gets to the fundamental question of, like, what is an organization? Why would we support these national organizations? And you could say, well, there's lots of talented health experts in a country like Zambia. So, why can't anybody just hire those experts? Like, why do you need to build an indigenous organization? And I think it does get to this point that ultimately what an organization brings to the table is different than just what a collection of experts bring. And a lot of what's different is that infrastructure that lasts over time. A CEO can come and go. Certain key people and key functions can come and go, but the organization can last and deal with lots of different challenges that come up over time. It can grow. The knowledge and learning can stay within it. There is something to that. And I guess I wonder, just on that point, whether you think the definitions, because we're talking, there's interesting nomenclature issues and definitional issues, right? Carl Hoffman at PSI often says, hey, let's not use the word local, because it makes these organizations sound like really tiny and insignificant, when really we wouldn't say that maybe about an American organization. We would use a word like national, because a lot of these, like the one you ran, are pretty significant organizations. They're not just local, they're big. But secondly, like, what is an organization? Is a U.S. subsidiary of an international NGO a national organization? Is a South African subsidiary a national organization? What about a quasi-governmental organization or a university institute? How do we think about this? I just want to get your take on. We're using this language pretty loosely. How do you define it? How should we think about what is a local or a national organization?
Right. Well, I think what's most important is that we really have a diversity of organizations involved. There's no reason to be, I think, overly concerned with over defining, if you will, what represents an organization that has the local interest in mind. There are important reasons that the U.S. government needs to have certain standards about what makes for a local organization and what does not, vis-a-vis procurement and things like that. Taking a broader view, I guess I would say that I can just speak from having run a local organization and seen a lot of others. There is really nothing like the motivation that comes from an organization that is taking care of the people in the communities in which many people in the organization grew up in and have friends and family in, and having a board that is drawn from the best professionals across the society, and the ownership and the feeling of trust, and that is probably the North Star, if you will, for me in terms of sort of what a local organization is, and it enables a sort of stickiness, if you will, for public health professionals, as opposed to sort of drifting off to another country or seeking employment elsewhere outside of the area of need. It helps keep people focused on the issues of most concern to their communities, and I think that is a particularly special sort of something that those North Star organizations have to offer. But that does not mean that the next version has less to offer. So a spin-off organization from a large national or international NGO that has been there for years and is largely constructed of local citizens and has its own independent board, but gets some support from an international organization, has many of the same benefits as the North Star local organization that I referenced. So I see a need for diversity there. We by no means have begun to solve all the public health crises that we have in front of us. And so I guess I'm less interested in parsing those finer points and more interested in continuing to build and support that local capacity in diverse forms.
Makes good sense. We had a question that came in that also that what you just said makes me think of this question, which is really for younger people today, or maybe getting into a career in public health. How should they think about how this field is going to develop, right? So you're at Georgetown University. Take a Georgetown University student who wants to get into public health, global public health. Are the roles going to become very remote based, where you can work from home anywhere in the world because really you're just providing expertise through a platform like the one you and I are on right now? or is the career still going to be very field based? Are those roles going to sort of go away or change in some way because everyone's going to start looking to national professionals in the countries where the projects take place? How do you see it developing?
Yeah, I think that's a great question, and it has a lot of implications for the way that we, educate our future public health professionals. And I think there will be a continued need and desire to have a mix of professions and backgrounds and people coming from a variety of different settings to address public health issues around the world. I still to this day see the benefits of a local health system being able to get external input on something that brings expertise, maybe learned from a different continent even, that can be brought to bear there. The degree of the kinds of connections sometimes that people coming from abroad can bring to create new partnerships are really, really important. So but I do think that there is a shift that's needed, and it's more of a shift towards, if I'm a young incoming public health professional who wants to do global health work, it's more, how can I be a better partner? What kind of training can I bring that is going to be an asset in a local environment that I may be reasonably unfamiliar with? What is it that I'm bringing to that environment? And I think in the past, perhaps that was almost less of a concern. Maybe it was almost more of a given that someone coming from the outside had important knowledge that needed to be imparted. It is a very different situation now, and that's a good thing. It really must be about, are there some scarce skills, or is there a particular function that can be brought to bear that really adds value? And that could be everything from being really good at fundraising, or being really good at communications, or but it is not always going to be like the best epidemiologist, because so many of those public health skills are needed, are present already.
Yeah, that's fascinating. I mean, look, following the whole vaccine development issue of all these, vaccine candidates out there, a huge part of it is raising the money, right? And I'm guessing a lot of people when they got into the work around vaccines, they didn't expect a key success factor would be how good are you as a fundraiser, or how good are you as a communicator. But these are, in a sense, all global health, related skill sets that you need if you want to be successful in this complex global environment. I last year this time I was in Rwanda. I got to visit the University for Global Health Equity, and just a couple weeks ago interviewed on one of these videos Agnes Binagwaho, who's the vice chancellor there and the former Rwandan minister of health. And she talks about how a lot of the reason they built that university in the middle of nowhere in Busarto, far away from the capital, is they want people to learn what it's like to live in a rural area and to see the benefits, to understand, what it's like to do kind of community-based health in the places where really most of the global health needs are going to be located, and to understand those communities. And my guess is if you're a student at a major international school like Georgetown, where I attended, boy, it's a different world than where a lot of the places are that you're intending to go bring your skill set to. And that bridge has got to somehow be crossed.
Yeah, no, I think that's right. And, I will say that one of the things that hopefully this pandemic has brought to sort of visibility is that, we have tremendous, global health really is our domestic health as well. And I think we should be beginning to create less of a divide there. And if you say you're in global health, that could mean that you're acting part-time as a contact tracer for your state, and you may be engaged in supporting a local organization to do some fundraising, or coming up with a collaborative research project that ties together multiple countries in Southern Africa. Increasingly, I'm starting to see people develop careers that really are global health, and not maybe the traditional
that don't have that developing world dividing line. However, and just to that point quickly, there was a question that came in about, well, couldn't you see people coming from overseas to the US to provide some of their expertise. I think they didn't say this, but I'm guessing specifically around things like contact tracing. But just quickly, in the limited time we have left, the reality is, while that might be functionally smart, that someone could bring those skill sets to any location in the world, the money doesn't really work that way, right? The money is still often divided between the developed world and the developing world, especially given how small the total health budgets are in many of the low income countries we're talking about. And so I guess a question I have for you is, what do you want to see the global response, or the US response even, be right now to this pandemic for sub-Saharan Africa, for places like where you work in Malawi and Zambia? There's so far been not that much activity. There's a $12 billion potential inclusion in the next supplemental that might get through in Congress. There have been obviously moves by the Gates Foundation, the World Bank, and others. USAID has started to move some of their existing programming toward the pandemic response. Yeah. But what do you want to see happen? What do you think should happen at that level?
Yeah, it's very important that we act now. It is we have begun to work through some of the issues, particularly those relating to sort of the basic public health functions, and we've been able to build off of the platforms that exist from Global Fund, from PEPFAR. But we need to do a lot more than that, and we need to begin to do some of that backfilling that I mentioned before. We can't fight all those existing pandemics and this new one all in the same resource envelope. So I think there's three things. One is the humanitarian piece, and there we really need to get serious about our really going full bore into relieving food security issues, which I think are going to be some of the most prominent issues in the next couple of months. Look, there's a huge locust infestation, a record locust infestation in East Africa taking place at the same time that you have COVID perhaps beginning to worsen. And the effects of these lockdowns on nutrition are highly concerning. So I think the humanitarian relief needs to happen now. I hope that as part of that supplement, which is going to be probably in the trillions. And so if we can just take less than 1% of that, we can put together a very robust humanitarian relief package that really is in the interest of those we're trying to serve in the partner countries, but is very much in our own interest as well to see stability in many of these fragile nations. Second would be to backfill and bolster those existing programmatic functions like PEPFAR, like Global Fund, like PMI, like the TV programs. They all need additional resources to be able to protect the gains as well as leverage themselves for the COVID response. And lastly, I would say that supplement, I hope, focuses on global health access for the goods that are being produced. And there I'm talking about drugs and the kinds of access programs that we're going to need immediately. If we continue down the road of seeing antivirals that look pretty successful, as well as the vaccine category. And one of my fears is that we see the kind of broad competition that we're seeing around PPEs translate into the vaccine environment. And if we see the inequities that exist now applied to vaccines, we're going to have a whole bunch of people who are getting the vaccines who don't really need them. And those who are most vulnerable, most at risk, in many cases in high density, lower income countries, not get the vaccines. That's a disaster for those countries. It's a disaster for the world. And so we do need to act. We need our Congress to sort of look outside and take action for everyone's benefit on that supplement.
Yeah, and you mentioned a couple of the global platforms that we have out there, and really we are in a different place than we were. We've got Gavi, we've got CEPI, we've got Global Fund, we've got PEPFAR, as you mentioned. So there are national, U.S. government and these multi-stakeholder global partnerships out there. There are platforms that exist today that presumably are going to put us in a much better position if we only can provide the funding to them. We're so much further than we were, let's say, 5 or 6 years ago, I think, in terms of getting to the strength in health systems, knowing how to do that, knowing how to fund national organizations. we're just in a position where if the funding were there, there's a lot more. It seems like the global health and development community could actually do with it today.
Yeah, I think you're right, Raj, and particularly on that third point, right, around the science and these kinds of new developments that we've got. Yeah, CEPI provides a great example of that. A small investment from the U.S., like a $200 million investment from the U.S., which is just a small fraction of what we're talking about overall, is then leveraged by the contributions of many other countries. And they have, CEPI working with Agavi, for instance, there's a global access imperative there. And that didn't exist, as you said, years ago. And so now we have a great potential platform to help right some of the inequities that would otherwise exist in the distribution of a vaccine, if we're fortunate enough to have one in the next year, a year and a half.
Yeah, just one last question for you. Given that you've got innovation in the title of the center that you're affiliated with at Georgetown, and I've been talking to lots of people who are thinking of this opportunity now in a way. This pandemic is a crisis, but there's maybe an opportunity to bring innovation to it to respond faster in a different way. Thinking about CEPI, they're using an innovative vaccine platform. What are the opportunities right now to thinking about connectivity and mobile devices and diagnostics at point of care and other kinds of innovations? This is 2020.
Yeah.
What can we do now that might be just different than it was a decade ago in terms of rapidly responding so that we don't see the crises that are possible, but we want to avoid in the lower income countries of the world?
Yeah. Look, one of the most innovative things that I'm seeing right now is the ability to try and bring a more targeted public health approach, and to think about not just everyone getting everything at once, but thinking about where the risks are and then trying to allocate and apply your public health resources to those risks. And what we're seeing in Malawi is really interesting. Malawi is one of the poorest countries in the world, yet they actually have a digital health and quality unit in their Ministry of Health, a digital health unit that is creating standards for the country and that is beginning to use predictive risk modeling to take into consideration the age structure of various communities across the country, to take into consideration de-identified mobile network data so they can see the movement of people and they can understand where they're going to have those pinch points and where they're going to have the greatest risk. You can imagine that that's very important for PPEs. You can imagine that's very important for healthcare worker allocation, community healthcare worker allocation, and ultimately the vaccine strategies that are out there. So it's exciting to see countries begin to apply some of those innovative approaches to their public health response. And there's so many other examples.
Well, that is very apropos of Debbie Burke's, right? Her focus at PEPFAR has been follow the data, use analytics to see where the outbreaks are, where the burdens are, and be able to target those populations that need the funding most, that need the treatment most. And that's interesting to hear. That's a really big opportunity here as well, to use the data analytics that exist today that wouldn't have been so easy to access maybe a decade ago.
Yeah, and of course we have to be very mindful of the fact that those are models and they're not always right. And so we need to be flexible. And but we also need to be mindful of some of the privacy concerns. And
Sure.
I think that's one of the areas that I'm very interested in and trying to understand how far we want to go with some of these technologies and what some of the limits should really be.
Just as we wrap up here, since you're, we're talking localization and you're running programs in Malawi and in Zambia, I'm just curious to know, when do you expect that you'll get to go back to those countries? When's the next time you plan to be on a plane to Southern Africa?
Yeah, well, I hope it's not too long, but I will say that the expertise on the ground is so amazing that we're doing okay right now, and I do hope to be back in country in the next few months, and crossing my fingers that that's possible.
Yeah, well, let's see. I mean, this is a key question in part because, it just gets to how significant the shifts are going to be for the way global health and global development work gets done. I mean, this is a field where as you know, lots of us are on planes all the time. There are conferences, there are field visits and missions. And, if that gets disrupted for 18, 24 months in a significant way, it might have really long-term lasting effects on the way we all work, some of which might be really good and really good for
I
development.
think so.
Yeah. So really good to get a chance to catch up like this, Charles. Thank you for taking the time to do this. And thank you to everybody who's been following these conversations live and on DevX. We really appreciate your support. If you're not already a subscriber to DevX's various newsletters, sign up and you'll find out information about these kinds of videos. If you are a professional working in this field, you should think about DevX Pro, which is our professional subscription utilized by people all over the world who work on these issues every day. And we're here for you at DevX. So stay in touch, follow us on social, let us know what's on your minds. And thank you, Charles. Really appreciate it.
Great. Thanks, Raj. Thanks, everyone.